We are finally getting to the part in the book where Shrier talks about the medical treatments for trans and or non-binary youth. If something in this book were to cause irreversible damage to people, it would probably be in this chapter. Strange that this would come so late into the book after everything else. This video made possible thanks to the continuing support of viewers, patrons, and PayPal pals like you. Thanks! Hi, welcome back to this cognitive psychologist deep dive that's so deep you need special licenses into Abigail Shrier's Irreversible Damage. And the underwater cave we're diving into today is puberty blockers. Good times. Quick refresher on the visual shorthand to indicate who is talking in these videos. This means I'm paraphrasing the book, and this means I'm responding to the book or integrating my thoughts with science. Or if we're discussing Shrier's general endnotes, several of which this time around are just very, very long footnotes. Okie doke, time for the transformation. Except not really, because we're only going to get to the puberty blockers step, which isn't really transformative, but ooh. This chapter starts off with not quite a full page talking about the TV show Bones. Bet you can see where this is going to go, because it's inevitable. Seriously, there is a page talking about the characters, actors, typical plot structure, and so forth. The point of this was to set up that the forensic paleontologist could identify the sex of the bones. Come on, Shrier. I never watched the show, but it took me a couple seconds to look up and see that she was supposed to be a forensic anthropologist. Paleontology deals with the really old shit, not something that would be of interest to the FBI.
Millions of viewers found this plausible. Turns out, they were right. I interviewed 3 forensic anthropologists, and each confirmed for me that with an adult skeleton, sex is easy to spot. Men's bones are not only much bigger, they have on average 50% more bone mass than women's, but many bones, including the pelvis, femur, and skull, also have a sex-specific morphology, meaning they are shaped differently too.
And note 1 is just Shrier thanking a Dr. Marian Rutigliano for pointing this out to her. From what I can see, Rutigliano seems to be an internal medicine doctor who also does anesthetics, has 0 reviews on the couple of doc review websites, and an IMDb credit for appearing in The Medical Harms of Hormonal and Surgical Interventions for Gender Dysphoric Children. This video is posted on YouTube by the Heritage Foundation. Small wonder why Shrier was talking to her, I guess. As for the meat of this quote, well, we have a bit of a rabbit hole to go down. Yes, there are many differences in bone features between males and females who went through an average puberty. And some of these differences are even observable prior to puberty, like certain bone lengths. However, it seems that trans youth who are taking hormonal treatments will develop bone features in line with the form of hormone that they're taking. This isn't surprising, as your body's essentially programmed to respond to signals like hormones, and if something has 2 possible signal variants, and the one that your DNA is programmed to do is muted, and you're introducing the other signal, your body's going to develop according to the instructions for that other signal. Still good to check though. A little bit of a complication for something later this chapter, at least for your bones, the age that you start puberty is important for your later bone health, with a later onset being associated with lower bone density. So that, combined with the general effects of the different sex hormones, may put a subset of the trans and non-binary community at higher risk of osteoporosis and bone fractures. So regarding Shrier's argument here, for people who went through the puberty assigned at birth, yes, there are structural differences in the bones, but those differences can be tweaked to a small or large extent depending on what hormonal treatments are done. Shrier continues this thread, eventually getting to a gender essentialism point.
As any biologist will tell you, sex in humans is much more than a few spare parts. Long after our organs have liquefied, skin begun to recede, our cells converted to nitrogen, and ligament casings have surrendered our teeth, when everything that made us identifiable to those who knew us is gone, maleness or femaleness remains. Gender transformation is, by any measure, an uphill battle. And yet, this is precisely where transgender identification leads. After all, you can only insist that you're trans for so long before so many doubtful looks from peers silently prod. Prove it.
I think I've addressed this already in the previous discussion about bones, so let's move on from this idea. After pointing out that she's still opting for the transgender identified language, something popular in the gender critical crowd to delegitimize trans people's identities.
Remember that for all the cultural purchase of a transgender identity, it comes tethered to an underlying psychological discomfort in one's sexed body. Sufferers of gender dysphoria can find their bodies endlessly distressing. There are treatments and surgeries to meet every physical fixation. Since the motivating ailment is not physical and observable, but mental and vague, there is no natural end to the series of medical treatments that call themselves remedies. Like the distress itself, the cure runs on and on.
It would seem Shrier is still rolling with the idea that you must experience gender dysphoria in order to consider yourself trans. A non-binary or gender fluid identity isn't even on the table at this point. I guess we're also no longer talking about social transitions, as those don't involve the medical interventions that she's rallying up fear for in this chapter. But of course, we're coming back to the, as we sort of understand it, psychological nature of gender dysphoria, which means there isn't a blood test or scan you can do for it, which now apparently means that a person can never be happy in their body. Which fits with Zucker's therapy framework, I suppose. Get gender-questioning youth to accept their assigned gender to avoid the gender-affirming treatment later on. We'll get to an example of a trans person that Shrier spoke to later this chapter, but I have to wonder if she's got a representative sample here. I've seen a fair number of trans and or non-binary people on places like YouTube or Twitter indicate that they're pretty happy with where their body is post-transition. There may be some slight modifications they're still interested in pursuing, but that's honestly probably true for a lot of cis people as well. Basically, it seems like there comes a point where the series of medical treatments stops, and you're pretty much just doing maintenance with like hormones. Final thing. Keep in mind Shrier's probable intended audience for this book. It is probably, at least in part, parents of AFAB youth. Some of these youth may have come out to their parents as trans, non-binary, gender non-conforming, or something. Some may just be gender non-conforming but haven't said anything to their parents, and some may just be AFAB youth. The tone of this is playing up the horrific existence that may be in store for their kids if they don't force them on the right path. Like, honestly, in the therapist chapter, Shrier accused practitioners of blackmailing parents into accepting their kids' gender identity and expression under threat of suicide, but at least the suicide statistics are rooted in fact. But this, your kid's life is going to be endlessly distressing with no stop in their drive to change their body, but only if they're trans. Doom. Doom.
Puberty is a sweeping metamorphosis. If your kid's pretty sure they're going to want to be a trans man, why make them travel there by way of breasts, hips, and menses? Gender doctors like to insist that halting puberty at onset, typically ages 8 to 13, is a neutral intervention, or pause button, since if the blockade is withdrawn, normal puberty should resume. Like freezing your eggs, blocking puberty is presented as simply allowing an AFAB youth to put nature on hold while keeping their options open.
Of all the things Shrier could have referenced for this, she chose a page from The Gender Creative Child, Pathways for Nurturing and Supporting Children, and that page isn't in the book preview. The Goodreads reviews for this book are generally positive, so I can't get my hands on this book without paying for it, and this is a single page that she's referencing and a relatively common claim, so we're gonna give this a pass. I don't know if puberty blockers are quite the same thing as freezing eggs. Freezing your eggs is a lot of time, money, and effort to kick the potentially having childbearing can down the road. Puberty blockers aren't so much about delaying kicking the can down the road so much as trying to figure out which road is best to kick the puberty can down. Shrier says Lupron is the go-to puberty blocker, introducing it as being previously used to chemically castrate sex offenders, as well as to delay puberty that starts too early. Reference 4 is an interview with a man who identified himself as a sex addict after his wife found out he'd been seeing sex workers for 8 years. He describes Lupron reducing his sex drive that was previously insatiable and all-consuming. It does include a little about the history of the drug, but there are a multitude of other sources that, admittedly, don't have as salacious a title. And while we're here, there's mixed evidence for the efficacy of chemical castration and getting people to stop doing that. Lupron is one of the ways that puberty blocking is accomplished. Given Shrier's propensity to cling to the technicalities of medicine, this next part isn't surprising.
What the FDA has not approved is using Lupron to halt normal puberty in anyone, transgender identified or otherwise. In general, doctors don't like to interrupt healthy endocrine signaling based on the say-so of minors, and gender dysphoria has no observable diagnostic criteria. There are as yet no reliable studies that show Lupron is safe for these kids. All available studies note the low quality of evidence or contain similar caveats. Nevertheless, endocrinologists have been administering Lupron off-label to gender dysphoric minors in ever-increasing numbers for a decade.
We're going to spend some time here with an article from the American Academy of Pediatrics on off-label drug use in kids. Off-label literally means that the prescribed use isn't included on the drug's full label. You know, that massive printout you get when you get your prescription. To quote the Drug Committee of the American Academy of Pediatrics, it is important to note that the term off-label does not imply an improper, illegal, contraindicated, or investigated use. It just means that the full clinical investigation has not yet been carried out for that drug. Again quoting this article, the absence of labeling for a specific age group or for a specific disorder does not necessarily mean that the drug's use is improper for that age or disorder. Rather, it only means that the evidence required by law to allow inclusion in the label has not been approved by the FDA. This can mean that there is research on using this drug in certain populations for a certain thing, but it can be below the FDA's threshold for substantial evidence. A medication being prescribed off-label also doesn't mean that the use of the drug is improper or unsafe, although it can mean that insurance won't cover it. Also, clinical trials are less common in pediatrics, so doctors have to use their best, hopefully empirically guided judgment. In practice, this means having informed consent conversations with the parents, which includes risks, benefits, and alternatives. And all this sounds like pretty standard practice for puberty blockers in trans and or non-binary youth. There's even the added wrinkle that doctors recommend staying on puberty blockers only for a relatively limited window, a couple years tops generally, before the youth needs to decide what they're going to do, either go through the puberty that they were assigned at birth or pursue hormonal treatment. Now, about these endocrinologists. I may have found the guideline by the Endocrine Society that lays out the appropriate treatments for gender dysphoric and or gender incongruent people, including youths. And wouldn't you know it? As long as the youth isn't prepubescent, meets diagnostic criteria, is able to be treated safely, and wants the treatment, the Endocrine Society says this youth should be given puberty blockers. I don't know how many times we've hit this no observable diagnostic criteria point, but it's certainly recurring enough to get a guest starring credit. To keep some spice in this discussion, we're going to try a different comparison. We're going to skip an argument that I've made in this series already, that for a lot of psychological disorders, there aren't definitive blood tests or scans or tests that you can do for a person to see, yes, 100% you have this psychological disorder. As, at least for anxiety, Shrier seems to think that they might be overdiagnosed or just blown out of proportion. We're also going to reiterate but not elaborate on the importance that a person does not need to experience gender dysphoria in order to consider themselves trans and or non-binary, despite Shrier's claims to the contrary. We're going to talk about migraines. A lot of symptoms for migraines are something you need to take the person's word on. Yeah, if they're vomiting, that is something observable that you can see, but auras, the pain, the sensitivity, you just have to believe the person that they're experiencing those things. Treating migraines. If you're lucky, it can involve things that you can just walk down and buy at like a CVS or Walgreens, just painkillers like Excedrin, not sponsored. If you're less lucky, it can involve prescriptions like Topamax, triptans, antipsychotics, antidepressants, and so on. Prior to 2014, using Topamax to prevent migraines in youth would have been off-label. It was actually the first medication to get FDA approval for that age group, so all the other options are off-label as well. Now, to state the obvious, a debilitating headache is not the same thing as being trans and or non-binary. But in both of these instances, you have to listen to the youth and take them at their word about what they're experiencing. And pursuing medical treatments for these can involve benefits as well as risks and side effects. So whether we're talking about migraines or people who are trans and or non-binary and are looking at medication options to help them be more comfortable with their body, there needs to be a discussion between the person and their doctor about the benefits and risks and side effects that they're looking at with these different medications. In the case of youths, especially under 15-ish, the parents tend to be involved as well. Everybody needs to be involved in this discussion of figuring out what the best treatment plan is for the person who is experiencing whatever. Because the person said they're experiencing something, the parents took it seriously, hopefully, and so treatment options are being pursued with the doctor. This is where we'd be talking about Shrier's evidence for lacking reliable studies, or low-quality evidence, or even the rise in Lupron use, if she provided any. Having had some experience with this book, if she did have something, it would probably be like a gender-critical blog post or something. So, lacking FDA approval for puberty blockers isn't a black and white issue. Endocrinologists actually do trust youth and are okay blocking puberty for a couple years, and her claims about lacking quality research and the hints of doom and increasing treatment rates are unsubstantiated. At this rate, this series should be subtitled An Application of the Bullshit Asymmetry Principle.
But is Lupron actually a neutral, low-risk intervention? Imagine you're a 15-year-old AFAB youth. But unlike all of your friends, you have no pubic hair. You've never had a period. You have no breasts. You've never experienced orgasm. In terms of size and function, you have the vagina of a prepubescent child. Sound like a neutral intervention?
Holy shit, Shrier. Tell us how you really feel. I'd say that this is suggestive of what Shrier considers critical hallmarks of femininity, but by this point in the book, we have plenty of evidence that she has a gender essentialist perspective. Gender is your body. So of course, not having this list of traits would not be seen as neutral, given her belief that these youth aren't really trans and or non-binary. Maybe it's because I'm cis and or because I've been in my adult form since I was 12, conservatively. I started menstruating in 5th grade, so fun times, but I was never really concerned about the status of pubic hair or menstruation in my friends. And now that I think about it, this is pretty demonstrative of Shrier's inability to take the perspective of a youth who is trans and or non-binary. The lack of period and breasts for an AFAB youth with gender dysphoria would probably not be distressing. The presence of them would be. This is also assuming this youth would have exclusively girl friends, which is a misstep of internal logic on her part. Part of Zucker's treatment approach for kids was to strongly encourage them, if not outright force them, to have a friend group of gendered kids similar to what they were assigned at birth, which would suggest that if these kids were left to their own devices, they would have friends more in line with their experienced gender. So then this hypothetical teen could possibly have guy friends, or other gender non-conforming friends, or, a mixed friend group, heaven forbid. But if they have cis guy friends, they won't be growing breasts and starting their periods. If anything, their rocket ship will be growing into its adult form, which, for an AFAB youth who is trans and feeling gender dysphoria, could be discouraging in its own way. But then there's this other recurring fixation of hers, orgasms. And don't get me wrong, orgasms and other sexual fun can be a nice part of life, but it's by no means a mandatory part. But as we saw earlier in the book, it seems that an implication here is that these youth need to have some sexual experience, which will then unlock their true gender identity. Don't forget that puberty blocking can start when you've started developing secondary sex characteristics, which could be in the early teens. But this orgasm focus of hers completely glosses over the reality that if you're gender dysphoric, engaging in sexy times is probably going to be a very difficult and unpleasant experience. No amount of getting railed is going to fix that. Shrier's next major point is the role that sex hormones may play in neurological development. Reference 5 is a case study of one Brazilian AMAB girl who underwent puberty blockers at age 11. The researchers compared this youth's brain's white matter, intelligence, as measured by the WISC, a standard intelligence test, and voice prior to and after 22 and 28 months of puberty blockage. White matter because this has previously been shown to change in puberty, intelligence as a reflection of general cognition, and voice because, I don't know. We won't discuss it further. They didn't find a significant change in white matter, which would possibly indicate the maturation process not happening during this investigation. This youth's overall intelligence score, along with some specific indices, were lower after starting the puberty blockers. Note that her starting point in global IQ was 80, which dropped to roughly 70 in the subsequent tests. A person with average intelligence would score 100. 70 seems to be the cutoff for an intellectual disability, but even 80 would still make things like attending school more difficult. And while the authors include that she was tested for things like depression, other disorders like ADHD or autism do not appear to have been screened for. Those could have influenced her test scores, maybe even introducing some variability in testing performance, so this case study can't definitively say the puberty blocking resulted in the drop. I've mentioned on the channel before that when I was younger I was in the gifted program, and getting into the program required some intelligence testing. I missed out on a couple points because I wasn't talkative enough with the woman giving me the test. And there's no gentle way to say this. I was a first grader left alone in a room with this woman who kind of looked like the secretary from Monsters, Inc. And I was a little scared, so kind of clammed up. The WISC is generally a pretty reliable test, but there can be environmental factors that introduce a little bit of noise. So, this case study found lower intelligence scores and no significant change in white matter in a trans youth on puberty blockers. Maybe this is indicating a potential cause of puberty blockers, but there are a multitude of questions left before the book can be closed. Is this effect consistent in larger samples, or was this effect particular to this individual? Because a case study does not a full clinical trial make. If this effect is replicable, is there a time dependency? Like, is 6 months going to have the same impact as 1 year or 2 years? The big one for me. Are the brain and cognition able to catch up once puberty is allowed to occur? Because if sex hormones are driving this maturational process, it's not like these kids are being kept on puberty blockers indefinitely. At some point, they're going to go through puberty. Is this actually just a pause in development, or is there a potential cost that needs to be incorporated into the informed consent process? We're at a point where there isn't really enough evidence to say what's definitively going on here. For me to accept that this is something to be concerned with, I want to see a longitudinal study that follows the same group of people as they go through the full course of treatment. Get the measures prior to starting the puberty blockers, during the course of the puberty block, and then after that, and then some. So they stop puberty blockers and don't pursue any further treatment. They pursue hormonal treatment, whatever it is, and then check back in with them into their 20s when they're adults and their brain has stopped developing. I wouldn't even ask for brain scans in this because doing that is hella expensive, and I think we would get enough information from a full battery of tests. So things like the WISC, other intelligence-ish measures, as well as screens for things like autism, ADHD, mood disorders, different things that are known to impact people's ability to do well on the different intelligence tests. And it's not large scale, but there is a case study that did this over the course of 22 years. The investigators did not find signs of problems with brain development or cognition, but more data is needed here. Shrier includes part of an interview she did with a therapist who resigned from Tavistock who said that blocking puberty isn't a neutral act, then loops back to the idea that this puberty-blocked youth would be alienated from girls their age, and then engages in some statistical shenanigans.
No surprise, then, that in a clinical trial, 100% of children put on puberty blockers proceed to cross-sex hormones. That is a stunning statistic, especially considering that when no intervention is made, roughly 70% of children will outgrow gender dysphoria on their own. Far from being neutral, the psychosocial effects seem closer to radical.
Let's talk about the references before we get into the sleight of hand that she's trying to pull here. We've talked about reference 6 before. Briefly, this is work out of the Netherlands that compared psychological measures between the start of treatment at the gender identity clinic and prior to starting cross-sex hormones. The primary takeaway from this paper was that some measures, like emotional problems or depressive symptoms, decreased, overall functioning got better, and unchanged were things like anxiety, anger, gender dysphoria, and body satisfaction. But yes, Shrier, all 70 teens in the study stayed on puberty blockers until they started hormonal treatment. But I reread the paper for this video, and I think this effect is actually an artifact of the experimental design. They had a pool of potentially eligible participants from a range of treatment years. From that pool, they selected the first 70 adolescents who had subsequently started cross-sex hormone treatment. It's right there. I'm a little ashamed I didn't catch this sooner. To be eligible for inclusion in this paper, these teens had to go on to hormonal treatment. And that right there just knocked all of the wind right out of Shrier's argument. Reference 7 has been used a couple times by Shrier. It was used in the same argument in the therapist chapter, and in the dissonance chapter to support the claim that a person's gender identity is changeable, in the context of conversion therapy for trans and or non-binary kids not being that bad, actually. As discussed in the therapist video, Shrier's definition of watchful waiting sounds more like conversion therapy, as opposed to the paper's description of allowing kids to develop on their own, without pushing them towards any gender identity or expression. With regard to the statistic, all it really tells us is that of all the kids who are referred to the gender clinic for treatment, not all of them will go on to identify as trans and or non-binary. But kids could be referred to treatment for any number of reasons, and gender dysphoria is just one of them. Basically, this statistic does not say that 100% of the kids who identify as trans and or non-binary aren't actually, or that hormonal treatment or puberty blockers aren't appropriate. The sleight of hand it seems Shrier is doing here is that these two papers are directly linkable, that you can apply the percentages from one to the other. So the study with puberty blockers, there actually would only have been 30% who should have received that treatment. The other 70% would have grown out of it had they not been put on puberty blockers. But that is simply not the case. Trying to connect these two papers directly is not the correct thing to do, as the 100% paper had that 100% continuance from puberty blockers to hormonal treatment through inclusion criteria. The number of teens who didn't continue to hormonal treatment is not included in that paper. Shrier lists out some of the possible risks of puberty blockers with the Brazilian case study referenced as support. These risks include, quote, suppression of normal bone density development and greater risk of osteoporosis, loss of sexual function, problems with brain development, and a hit to possible max IQ. She says that the severity of these risks is not yet known, but that these risks are higher if the youth goes to hormonal treatment after puberty blockers. Additionally, doing so almost guarantees that the person will be infertile, sexually underdeveloped, and maybe can't orgasm. We already talked about the Brazilian case study and why it can't tell us much about brain development and IQ. But it says nothing about bone development or sexual function. Nada. Towards the beginning of this video, we touched on the bone costs associated with the different hormonal treatments for trans and or non-binary people. It may also be possible for teens to catch up in bone development once they stop the puberty blockers, although again, more data is needed there. General sexual function is a rabbit hole, with all the sexiness that clinical discussions of these things can muster. Ooh baby. The 22-year spanning case study I mentioned earlier reported the individual's ability to orgasm, but having had a hysterectomy and gonadectomy certainly impacted his fertility. As summarized in the position statement by the European Society for Sexual Medicine, people who have undergone gender-affirming medical interventions still generally have satisfying sex lives, including orgasms. An editorial in The Lancet, Child and Adolescent Health, indicates that the claim that puberty blockers causing permanent infertility is false. With regard to impacts of puberty blockers on fertility, it seems that puberty blockers do not result in long-term fertility impairments. It gets a little trickier for trans women, but for trans men is generally reversible. So altogether, we can't say anything definitive on the possible brain development or cognitive impacts of puberty blockers, but the potential long-term effects on bone density and short-term effects on fertility are known, and all of this seems to be pretty standard in the informed consent discussion prior to starting treatment. If puberty blockers were continued indefinitely, there would potentially be impairments in sexual function and satisfaction, as the maturational process of puberty would not happen, and so it wouldn't work as it would as an adult. But people choosing to do that are the very rare exception rather than the rule. Most people, after being on puberty blockers, will go through a puberty, be it the one that their DNA is programmed for or not. But Shrier had an endnote here, and it sure ain't a reference. Yes, the Tanner stages are as described by Shrier. The Endocrine Society recommends starting puberty blockers at Tanner stage 2. And yes, if the adolescent goes from puberty blockers to hormonal treatment, their built-in reproductive system won't really get to mature. But this part about orgasm does not seem to be true. It bears repeating that this should be and is part of the informed consent discussion for this treatment, as practitioners want their patient and their family to fully weigh the costs and benefits for the treatment, including fertility. If the teen thinks at some point down the road they may want biological children, the hard, cold reality is that they need to go through the puberty assigned at birth in order to provide the reproductive material to do so. Now, depending on circumstances, there can sort of be ways around this. As a similar-ish example, I knew somebody who was a married lesbian who had biological children with her wife, and they did this through the miracles of modern medicine. And basically, they used her brother-in-law's sperm to fertilize her eggs, so sort of biological children, but not quite. And certainly that isn't an option for everybody, and it was hella expensive, so yeah, this is definitely something that the teen needs to consider before they commit to whatever path they're going to go down. But the thing is, being on puberty blockers gives them some time to mull these things over. Shrier spoke to Dr. William Malone, an endocrinologist, about this. She calls him, quote, one of the country's most outspoken critics of administering puberty blockers and cross-sex hormones to minors. He told her doing these treatments for a long enough period is like putting the system in a permanent sleep state. Doing a search for Malone indicates that he's relatively well reviewed by his patients in Idaho and is active in trying to, at the very least, question the current standards of treatment for trans and or non-binary youth. This StopSafeSchools.com is the website for the Coalition Against Unsafe Sexual Education, an Australia-focused group opposing teaching LGBT gender ideologies to children. Malone has a page there that is a sort of annotated bibliography of research, or blog posts, on gender dysphoria, a fair number of which we've already talked about in this series. As a sort of combination of our very favorite things, apparently Blanchard wrote something for Fourth Wave Now, the gender very critical website, which was one of the participant recruitment locations for Littman's Rapid Onset Gender Dysphoria paper. Well, co-wrote with Bailey, the man who wrote The Man Who Would Be Queen, if you actually look at the post. What is it with the poor source handling in this space? Seriously. Malone is also part of the Society for Evidence-Based Gender Medicine, a US nonprofit that claims to be free from political, ideological, religious, or financial influences. Right. The "it's only ideology when the other side's doing it" logic. There does seem to be a bit of a disconnect between saying that young people with gender dysphoria deserve respect, compassion, and high-quality care, and building a not insubstantial amount of their case on Littman's ROGD study, which wasn't really respectful or compassionate towards the trans and or non-binary people whose parents were interviewed.
It's worth noting how great a departure this is from normal medical protocol. When we allow parents to consent to medical procedures for teens or tweens, it is typically to permit doctors to save, cure, or alleviate an observable medical problem. But in the singular instance of transgender medicine, we allow a parent to consent to intervention that halts normal, healthy biological functioning, essentially introducing a disease state brought on by a pituitary tumor, all based on self-report mental distress.
So much of this departure argument hinges on gender dysphoria not being an observable medical problem. And given what she said about anxiety, it may be the case Shrier doesn't consider psych disorders medical problems. But earlier this book, she outlined the diagnostic criteria in the previous and current versions of the DSM for gender identity disorder and gender dysphoria, respectively. Those diagnostic criteria include observable behaviors. Even in the parental stories shared in this book, the parents describe these behaviors even if they won't accept that their child is trans and or non-binary. She's appealing to this idea that things would be hunky-dory for these youths if these treatments weren't carried out. Despite Dr. Malone's extensive claims, there is evidence-based medicine supporting the standards of care put forward by the different medical, psychiatric, and psychological organizations. Endnote 10 is a lot. Let's start with the research paper. They were interested in the self-reported effects of puberty blockers and later mental health. This paper used the 2015 US Transgender Survey as its data source. The survey has also popped up several times in this book. The authors only included data for the subset of survey respondents who could have received puberty blockers in the US, as that was only available after 1998. An additional inclusion criterion was that the respondent had to have indicated an interest in taking puberty blockers, which cut the data pool down to just under 4,000 from the nearly 28,000 who took the survey. Of those 4,000, only 89 actually received puberty blockers. The variables associated with being able to receive that treatment were a younger age at time of survey, the age of social transition, age the person started hormonal therapy, having a feminine gender identity, being assigned male at birth, having a heterosexual orientation, higher household income, and greater family support. Furthermore, being treated with puberty blockers was associated with lower odds of suicidal ideation in the past year, lifetime suicidal ideation, and severe psychological distress in the past month, as shown in Table 2. When they controlled for demographics, puberty blocking treatment was associated with lower odds of suicidal ideation overall. In the discussion, this table is referred to when drawing the conclusion that approximately 9 of 10 transgender adults who wanted pubertal suppression but did not receive it endorsed lifetime suicidal ideation. Other discussion points were that the majority of transgender adults in the US who wanted puberty blockers did not receive that treatment. Receiving this treatment was associated with a higher household income, which fits the situation in the US, as the cost for these treatments can range between $4,000 and $25,000 a year if not covered by insurance. Straight participants were more likely to have had puberty blockers, which fits into previous research that indicates non-heterosexual attracted trans people are less likely to use gender-affirming treatments. Unsurprisingly, familial support was associated with treatment access. They note that they did not find a statistical difference in suicide attempts, but this could be a result of inadequate power and/or not being able to get survey data from people who were successful in their attempts. Overall, they close by saying that this article provides support for the benefits of puberty blockers for those who want this treatment, and it backs up the Endocrine Society and WPATH standards of care. Now, what did Shrier say about this? Right out the gate, Shrier is misrepresenting what's written by Turbin. They didn't find a statistical difference for suicide attempts, and the only part from the New York Times piece that could support this idea is mention of a separate study that found that conversion therapy is associated with increased risk of attempting suicide. While all of this should absolutely be taken seriously, this was not something Turbin's team found in their study. This, in the year since his data was collected part, indicates Shrier not quite understanding the measures of this survey and paper. I don't even know how this would have logistically worked for this survey. The question was about suicidality or suicidal ideations in the previous year, not anything about the year post-survey. But yes, 50% of the 89 people who received puberty blockers had suicidal ideations in the previous year. That has to be compared against the 65% who did not receive puberty blockers. Both numbers are distressingly high, but that doesn't mean this treatment isn't important. Her implied argument is that because we can't get this number to 0 through puberty blockers, we shouldn't do it. With regard to the data involving attempted suicide, I'll remind you that they didn't find a statistically significant difference there. And sure, looking at the rows of interest, the percentage is larger in those who received puberty blockers versus those who did not, but the difference is 3 percentage points in the first row. At the very least, this is something that warrants further research to get a more solid idea if this is a possible risk or not. But right now, it's in the noise. The second row has a larger difference percentage-wise, but with the small sample in the puberty block group, it's impossible to draw definitive conclusions. While we're here, it's also worth pointing out that the trend is reversed when you look at lifetime suicidality. And in this case, at least for lifetime ideation, there was a significant difference between groups. My conclusion for this mammoth endnote is that Shrier's getting sneaky with the statistics again. But, as they say, there's lies, damn lies, and statistics. I think that's as far as we're getting into this chapter for now. The tour of some common arguments against one form of treatment for trans and or non-binary youth took substantially more effort counter-arguing than I had anticipated. But hopefully this will lay some groundwork that we can just refer back to as we get into the hormonal treatments, because Shrier did sometimes interchange the two, and I doubt that's something that she would just drop moving forward. So until next time, bye!